All right, let's start. People can join as they come along. Good afternoon. My name's Ray Thomas. I'm the Research Education Lead for the Tropical Australian Academic Health Centre. And welcome to the very first 2025 webinar of the year. We've got quite a nice lineup for you this year, so keep track of the invitations that come out monthly and get promoted, because I like some interesting stuff. I've got a program of stuff that, quite frankly, I'm excited about, but keep having a look. So I do hope you've come prepared today, because I'm going to ask you to write down some questions that you have for the panelists that are going to talk today, but also some ideas that you might sort of generate as you're listening to what we're saying and thinking. I am going to ask you about that, so make sure you start writing things down, because this is an interactive webinar. It is not passive, so don't forget to do so. All right. So today, the very first one is about research translation: what, why, and where to get good ideas. So before we start, I'd like to acknowledge the traditional custodians on the land in which we all gather. I live and I work on the lands of the Woolgottokaba and Bindals people in Townsville, and I pay my respects to elders past and present. So for those of you who don't know much about TARC, let me kind of explain a little bit to you. The Tropical Australian Academic Health Centre is a collaboration between 8 different partners in northern Queensland. We are an accredited NHMRC, that stands for National Health and Medical Research Council, Research Translation Centre. It just gets wordy when you all put it all together. So 8 of our partners are the 5 northern HHSs. So that includes Townsville, Mackay, Torres and Cape, Cairns and Hinterland, and Northwest. It includes James Cook University, the North Queensland Primary Health Network, and the overarching body, the peak body known as QAIC, which is the Queensland Aboriginal and Islander Health Council. So some of the things that we provided to all of the staff members of those 8 organisations have these things that they can access for free. Doesn't matter on your discipline. It doesn't matter if you're a clinician or if you're an administrator. These are some things you can access. So we provide research training, all right? We provide design and study support. We provide statistical consultations and analyses, and we actually have some grant rounds and some fundings that we offer as well. And for those of you, who haven't ever investigated the TARC website, do so, because there's a lot of information there that is probably very, very pertinent to you. All right. Just some of the things that we might want to do to keep the webinar running smoothly. Just a couple of rules. Please mute your microphones if you're not speaking, and we'll have a session at the end to do a Q&A with the panel in particular. It'd be great in that session if you have the ability to have your camera on. It's always so much nicer to see people's faces rather than little icons. That'd be great. And please feel free to ask any questions you have of either myself or, most importantly, the panelists who are going to talk today. You can put them in the chat if you're shy, or you can raise your hand and ask them. Not a problem in the world. All right, so let's get started. I'm going to talk a little bit today about research translation, and I'm hopefully going to talk for 10 minutes only. But today's panelists, and who I really want you to hear about today, are Kate Ross, and she's from Northwest Mount Isa. Felicity Dick is from Townsville, HHS, and Ben Glenwright is from Cairns and Hinterland, HHS. And these guys have done the stuff I'm going to talk to you about today. So these are the people that you need to kind of quiz about how can you start your journey in research translation, being clinicians or being administrators. How can you actually tap in to their knowledge and the tips and tricks that they actually have? So that's why I want you to start writing down questions, right? Start thinking about this, because it's lots of fun. All right, I'll start. So what if I could tell you, right, that you could actually reduce the mortality in one of your wards from 18% to 1% by doing one simple, really easy thing? It sounds like it's no-brainer, right? You'd absolutely do it. Why wouldn't you do it? That sounds really easy. All right, what it is hand washing, okay? And in hand washing, did you know that the evidence was discovered back in 1848, but it took 132 years for that evidence to be translated into the first guideline for hand washing. And then it took another 29 years before it became a global health standard, right? So that's 161 years from research evidence to global standard in clinical practice. And we all know about hand washing. We all know about its importance. And we all do it all the time because it actually benefits our patients. Or do you? Well, you don't, right? In 2018, yes, that's right. Okay, we did an audit, right? We had a look at hand washing. And the blue bars are when humans watched, and humans did an audit about hand washing. And the blue bars tell you that about 90% of the time you hand wash. But when humans were taken out of the equation and we had video cameras there instead, that proportion of hand washing went down from 30% to 6%. So if we know it's important and we know that it can reduce mortality, why on earth aren't we doing more of it? Because it's hard, right? Research translation is about connecting two sides of a river, right? There's the research evidence on one side of a river and clinical practice on the other side of the river. And that bit in between is full of gaps, full of currents, full of rocks to stumble across. And it's really hard to get from research evidence to the clinical practice side, even when we know what we should be doing is a no-brainer, right? But luckily, there's a way in which to do it. And that's the research translation. And that's the bridge, okay? The research translation bridge connects one side of the river, the research evidence, to the other side of the river, which is clinical practice. Because we absolutely know that generating new research evidence and synthesizing research evidence and publishing research evidence is nowhere near enough to actually make research evidence translate into clinical practice. We've tried it, not enough. If I publish something 9 times out of 10, nothing is going to change. It doesn't matter if I publish it or not. It helps that I publish it, but it's not enough to change clinical practice. So what we need is that research translation bridge. And it's going to be smooth, and it's going to be connected, and it's going to be really easy to do. But if any of you ever tried to actually make somebody do something different, something that they might not necessarily want to do, is it a smooth process? Is it an easy process? No, it's not. Because your research translation bridge looks a little bit more like this, right? There are big gaps in the bridge. There are gaping chasms that you will fall into. And that's what happens in your research translation bridge. But we can close that. So what we know is that without research translation, the time between research publication and effective intervention and practice change is about 17 years now, right? If we use research translation and its principles, we can change that to about 3 years. And here's a bit of information. This is what I want you to think about. All right, research translation is something we all need to do. And research translation is about making sure that people are aware of and use effective research findings in clinical decision-making and practice. But what we need to know are, what are the gaps in our bridge? What are the problems? Why aren't people already doing it? Why aren't people washing their hands 100% of the times? What are the gaps in your bridge? And where are the gaps in your bridge? And that brings us to another term that we're going to talk about today, and that's called implementation science. And implementation science is how we get there. So it's a scientific study. I know that sounds boring. For me, it isn't. About how to promote a systematic uptake of research evidence into practice. And implementation science actually provides you with some tools that helps you figure out what are the gaps in your bridge? How are you going to fix them? What is it going to look like? All of that fits together really quite nicely. And before you move on, I really think it's important that we all get on the same page about some of the language that's embedded in research translation, because the most thing you'll find is people understand things very differently. And I found this a really easy way to think about research translation, and I use it a lot, right? So I'm going to read it to you. So research translation, all right, the intervention or the innovation is the thing you're going to do, right? Effectiveness research looks at whether or not the thing works. Implementation science, all right, looks at how to help people do the thing. And implementation strategies are the things that we do, the activities that we do to help people do the thing. And main implementation outcomes, depending on your study design, are usually how much or how well people do the thing. And then there's some clear steps to follow, and there are theories and frameworks and models that you can choose from that help ground your research project so that you're able to follow these and increase the likelihood of your success of your project. So let me just read these out to you. The steps to follow. You need to define the problem and select the thing. You need to identify who and what needs to do the thing. You've got to find out where those gaps are, right? You've got to find out why aren't they already doing it? What are the barriers? What's stopping them? Or they are already doing. What's helping them? What are the facilitators? What are the enablers that help them to do that? Then you're going to choose what we're going to call implementation strategies, which are the things that you do, the activities that you generate in order to help people do the thing, all right? Then you're going to give it a go. And then you're going to evaluate that and see whether or not it has worked for you. So what I'm going to do is take you through an example for a minute to talk to you about something that I've worked on before. All right. So let's talk about knee replacement surgery. All right. So here's what we do. We're going to define the problem and the thing. All right. So number one, the Australian Commission of Safety and Quality Guidelines say that almost half the people who have knee osteoarthritis are not managed according to clinical practice guidelines, right? And clinical practice guidelines suggest the first line management is non-surgical, right? So less than half of those people are actually getting that, right? So then the next problem is that there's been a 38% increase in surgery for knee replacements between 2005 and 2018. Now that suggests that there actually might be an overuse of surgery and an underuse of non-surgical treatment plans. And then the next thing is that, interestingly, there's been a fourfold variation in the rates of knee surgery. So between the lowest rate and the highest rate around the country is about 4 times different. So that suggests that there's something else going on. So what we're interested in doing now is that what we did was have a look at an audit. Let's pretend that you wanted to know about what's the surgical rates in your organisation, and you might do an audit to have a look at whether or not the surgical rates were high or not compared with the average around the nation. And you found, let's pretend, that indeed they were high. So now we know, okay, so you're higher than average. We know all this stuff. So the thing you want to do now is non-surgical management for knee osteoarthritis. Number 2, the second thing you want to do, identify who and what needs to do things differently. In this project, we figured out 3 different groups of people needed to do something different: the patients, the healthcare workers, and the local organisation. Why aren't they already doing non-surgical management for knee OA? All right, so what we did was we had a look at the research behind why they didn't, because you can either do this 2 ways to figure out what the barriers and enablers are. You can either go to the research and see if they have done any work on this and see if it contextualizes to your situation, or you can do things like surveys and interviews to find out from people in your organization what it's like. Or you could do both, right? We went to the research literature. And we found out that patients had negative beliefs about non-surgical management. They actually didn't think they're going to get better without surgery. They had really strong emotions about pain. And they also had strong emotions about not getting better and being bored with exercise, which is a non-surgical management. They also weren't really clear about the effectiveness of non-surgical management, so we categorised that as a knowledge barrier. We also found that professionals, healthcare professionals, had communication skills barriers. So they weren't really good at communicating with their patients about what their options were. They also didn't have a champion, so they didn't see anybody doing this. And they also believed that if they did this well, it'll increase their consultation times, which was a problem for them. And then the local organisations, they had no incentive to practice this way. It made no difference to them. So they weren't really engaged in why they should do something different. And the local context also didn't really have any non-surgical management options for people to be referred to. So there were some big challenges that they actually had. Then we get to choosing our implementation strategies or our activities. Now, when you're using some tools in research translation, there are easy ways to do this. This is not difficult. It looks tricky, but it actually isn't a tricky part of the process. So we found that by using these tools, when we knew that the healthcare professionals had communication skills problems, we were able to see that the thing that related well to that was skills training, right? That's almost a given. When we know that the patients had a knowledge gap in terms of the effectiveness of non-surgical management for NEOA, we decided to look at decision aids. What were their treatment options? With the local organisation, when they had environmental and context resources problems, we wanted to develop and deliver some very flexible and tailored interventions for people for non-surgical treatment options. So you can see that the activities that you could do, the implementation strategies that you can do, are deliberately mapped to match the needs of your barriers or facilitators in that. So you can see that there's a bridge. There's a process that you can follow. All right. The last thing that you have to do is check it out, try it, evaluate it. Usually, if you're doing implementation science studies, research translation projects, your outcomes, more often than not, are how much or how well they did your thing, right? But if you also need to check the intervention effectiveness, you can add that in too. That's not problematic. So there's a bridge to connect, right? The clinical practice processes and the research evidence, and there's tools to help. But where do you start? Right? And that's why I'm going to now pivot to our panel, all right? Because they've done this, all right? And they have looked at very effective ways to address and to figure out what's their evidence practice gap. So for the rest of the webinar, I want to start questioning and talking to our panelists. So I'm going to introduce them to you first. All right. So Kate, wave Kate, there she is. You can see her name. Kate's been at Mount Isa-based hospital since 2023. She's passionate and she's worked with people across the lifespan, but she's specifically working very clearly with children and their families. She's also really passionate about making healthcare interactions more comfortable for people. She is currently conducting a research translation project, and she's going to be ready to spill the beans to you in a minute. Ben Glenwright is a Cairns-based hospital senior physiotherapist in acute orthopaedic services. Ben's led research translation projects, and he's a really strong advocate for the staff in his group to actually have research translation projects also. And in fact, one of Ben's staff won an award last year for a research translation project that she did. Yes, Ben, waving Ben and nodding. So he's going to talk to you about his work, and he's also just published a piece, which is something that you can do also, about the barriers and facilitators of implementation of electronic PROMs and PREMs, so patient-reported outcome measures and patient-reported experience measures in healthcare. And we also have with us Felicity Dick. And Felicity Dick is from Townsville HHS, and she's been working in North Queensland for 11 years and currently the senior dietitian in the Townsville University Hospital, working across the acute wards. Now, Felicity's passionate too about research translation into practice and has optimised patient outcomes and providing value-based healthcare. And her project's really interesting too because she's used volunteers to help her in her project. And Felicity too has won an award for her research translation project. So the three people you have to talk to today are really good at what they do. And this is your opportunity to pick their brains about how they do things. But before you do that, I'm going to stop sharing my screen. I think that's right. Okay. And I'm going to ask the first question while you guys continue to write your questions. And so what I want to ask each of the panelists now is in about 5 minutes each, can you just let us know three things? What is your research translation project? What did you want to achieve by doing it? And what I haven't touched on today is you can't do this by yourself usually, so you usually have a team, right? So what I'm interested in is how many people and who are on your team? And then maybe tell me how you identified your gap. All right. So let's start with Kate. Tell me about yours.
Everyone. So basically the title of my project is procedural preparation as part of standard practice for children getting bicillin injections for the treatment of rheumatic heart disease. So big mouthful of a title, but basically how that all started is I started working in Mount Isa in 2023 after working for a year in private practice as an occupational therapist. When I moved out here, there was a bit of a culture shift happening in terms of how we view rheumatic heart disease and bicillin injections. We had I'm going to stuff up the name of this, but a colonial inquest into, unfortunately, some very poor care that some women up in Dumaji received relating to rheumatic heart disease. And before I sort of get into all of this, I'd probably like to pay my respect to those people who live with rheumatic heart disease and acute rheumatic fever. It's a horrible, horrible disease with a horrible treatment. And I suppose that the spark for this project really came from their experiences and their poor experiences. So hopefully something like this will help in the future for these children and families. But anyway, going back on track, I suppose it all started with that sort of red flags around, there's something going on here. It's Mount Isa Hospital and Northwest HHS are getting a lot of kind of poor publicity around this. And then I went to a Townsville University Hospital for a week of upskilling and kind of saw what their occupational therapists did in regards to procedural preparation on their paediatric wards. And they shared with me a lot of resources around providing procedural prep and pain management for children getting bicillin injections, which are a really, really painful injection that needs to be had like once every 21 to 28 days for like often cases over 5 years. So a really, really long-term treatment regime. And when I came back to Mount Isa, I got a couple of referrals for ad hoc procedural prep things on the wards. From there, I was kind of like, I don't really know what to do with these people. I don't really know the clinical guidelines for this. And a lot of the times the referrals, I was providing a subpar service pretty much, not the same service that would be provided at a metro facility where there's occupational therapists specifically trained in procedural preparation. So from there, I was kind of like, this is a massive service gap, especially when this is such a high-risk procedure and so important for survival. And these children aren't getting the same care that they would be getting in metro facilities. So that's where the inspiration for the project kind of came from. From there, it was really benchmarking with other health services, seeing what other places provide, talking with our staff here, seeing what we were currently providing, and from there figuring out what the gap was specifically. We did a staff survey about what we currently know about procedural prep, about procedural pain and how we can manage it with children. And it showed that although most staff that completed it felt it was really important and really wanted to know about it, a lot of staff didn't feel confident or competent in providing that intervention to children. So I was kind of like, okay. education and using the different implementation science models, which I won't get into too much because it's the project still progressing, but kind of had my ideal outcome is to have education and a sustainable sort of wealth of knowledge for procedural preparation for nursing staff across Northwest HHS to be able to provide procedural preparation or to seek help when they require extra assistance with those sort of children who are a bit more complex and avoidant of their treatment. So they can have access to something that people in metropolitan facilities would have access to. Also hoping to, yeah, sorry if I'm talking too much.
It's great, but I want people to be able to ask you questions too. But I really like the fact that it came from clinical frustration. It came from you wanting to be a better clinician. It came from a place of feeling like you wanted to provide a service that they could get elsewhere. So that's a really great place for you to start. And I love your process, clinical practice guidelines and audit. That's really neat. Ben, I'm going to pivot to you for a minute. Tell us about your project in brief and tell us about why.
Yeah, happy to. I guess I can talk to probably a couple of projects. So one I have completed a full cycle of, and we've just done a re-audit. So that was looking at implementing enhanced recovery after surgery for our total hips and total knees at Cairns Hospital. So that was quite a large project, and from who was involved from key stakeholders, that's everything from the anaesthetic department, orthopedic department, key allied health, nursing, and that's across the patient journey from pre-admission to discharge. So that was a lot of learnings happened through that. COVID happened, so that sort of limited us. And where my I guess idea came from is I attended a conference there, one of an orthopedic physio conference, and they spoke to ERAS at a facility. I'm like, oh, this sounds quite interesting. A lot of it came about, improved patient, experiences through decreasing nausea and vomiting post-op, managing their pain better, looking with throughput, so length of stay, and looking at things that really slowed us down. So things like patients always had what we call plastics. So they had IDCs, they had PCAs, and that was very common. And hearing, this presentation about that isn't common was quite intriguing. So looking at the literature, came across that at the time, some ERAS Society guidelines were printed, which were quite nice, and sort of laid it out in 17 key areas that needed to be implemented that were backed by research. And then we looked at the implementation of that and probably gravitated to quite a simple implementation science framework, being the knowledge to action gap sort of framework, and looked at things like setting up a working group. And I think we had 5 key players, but up to 15 in it. So learning a lot around coordinating, directing people to participate. And I think that's always a learning that I got from that. But then that's translated into a couple of other projects that we've done, and one like Ray did is I helped educate my staff to undertake that, and one of them was looking at hip precautions, which is archaic in the orthopedic setting. However, we still followed what was old practices, so looking at de-implementing that, and I've now taken on that project because they went off holidaying, continued that, and that sort of then also in that time I'm now, and I guess just showing the variety of doing it from a quality improvement point of view, but also I'm doing a PhD looking at self-directed rehab, and that's going to sort of the bigger version of implementation science and looking at implementing the research across many years there. Talking to, I think, that's me.
I like how you touched on the key stakeholders, and that's really important. Like, when you know who needs to do something differently, you actually have to have a way to bring them on board, and making them part of your team is the best way to do that. Of course, they're busy. I understand that. But if you can actually make them part of your team and have buy-in that way, it's an easier thing to do. Thank you for touching on that. That's a good tip for people to hear. Felicity, tell us about yours.
Hello. Yeah, my project, which Ray knows intimately as a mentor for us, is called Helping Our Patients Eat. So we call it the Hope Project, and it's using volunteers. We have a Brighter Lives volunteer workforce at the hospital. We're using those guys to help provide meal assistance at lunchtimes on a couple of pilot wards for patients. And the reason this came about was that we had identified the problem through long-term Eat, Walk, Engage audits that were done. And part of the Eat, Walk, Engage program is looking at nutrition, so the EAT, and they conduct mealtime audits looking at whether people get enough assistance, whether that assistance occurs in a timely fashion within 10 minutes, how much meals of the meal is consumed, whether it's less than half or more, and the reasons behind that. And we'd identified over the last couple of years, this was probably 20, when was this? 21, 22, 23. Yes, we did it last year, didn't we, Ray? Yeah, so the last few years of the 2020s, we'd had this ongoing poor outcomes in the eating domain for our Eat, Walk, Engage audits. And the Eat, Walk, Engage facilitators came to us as dietetics being like, hey, guys, what can we do together to help? We had a bit of a discussion around it, had a look at the literature. We knew that our volunteers were looking for additional jobs, and that's where the idea came from. We do have a big team, as you know, Ray, so we've got probably 5 or 6 key players on our core team, and then we would have regular working group meetings, which we pulled in our volunteer coordinator, our nurse CNCs from the wards in question. And our core team is very multidisciplinary. So we have 2 dietitians, the Eat, Walk, Engage facilitators. So we have 2 of those, our delirium standard lead, and a speech pathologist, and then Ray.
And me. Excellent. I'm going to ask you, participants, audience, do you have questions for these guys? I can see that some people have generated from clinical concern that they wanted to provide the care. I can see that some of you have clinical practice guidelines that you learned about and believed you won't follow. And then Felicity talked about, the audits and stuff, and that alerted her to a problem. So who has questions? What do you want to know from these people? Because they've done it. You're here because you're curious. Give me some curiosity. Kiralee, what do you think?
Hi.
Hello, Kiralee.
I'm here from the National Health and Medical Research Council.
You most certainly are, Kiralee. We can see your background.
Yes. Just very much here to listen and learn and hopefully take some lessons back to incorporate into grant opportunity guidelines and broader policy. So no specific questions from me at this stage, but very keen to hear what everybody else has to say.
Cool. Gupakuma, you have the question perhaps?
Hi, Ray. Thank you for the session. And Kate, my question is to you. In terms of your research, the initial step was to do a survey. And I generally find the response to survey, because that gives us the initial information on the perceptions and the magnitude of the problem. But I find surveys very difficult in terms of response rate, and it doesn't represent the whole. It doesn't capture the accuracy of the problem. So I was just wondering how you went about getting the survey done and making plans moving forward from there. And what was it? Did you have any logistical issues in terms of getting ethics approval? Because I had tried to do a survey a long time back, and the number of approvals and the questions needs to be screened, and it has to be. It doesn't have to. It was a multi-center. Then it had lot of hoops to jump through. So yes. I was curious about how you went about your survey.
Yeah, go for it, Kate. Yeah.
Yeah, look, it was this problem. I'm sure there's surveys that have beat it, but this survey was out for a long time. Like, I want to say, I was just trying to gain any information from nursing staff. We have such a transient workforce. So I guess in regards to your first question, getting responses was really tricky, especially given a lot of the nurses aren't really on their computers, and it was a Microsoft Forms document. So to get responses, I kind of went to like QR codes in all the wards that had nurses on them, linking with the NUMs and the DONs of different facilities, and also trying to get really good stakeholder engagement from the people who could really drive and like kind of force people to do that survey. In terms of approvals, I think I got pretty lucky, to be honest. I've definitely had lots of challenges in the past with, and like even now trying to get surveys from patients, is trying to figure out how I can get consumer feedback regarding their experiences is something I'm finding really challenging. But in terms of getting the feedback from staff, I think I had the right people on board with the project to sort of pass those approvals through. And the surveys were all anonymous and only provided and gave options to be contacted further. And a lot of the questions were, I guess, on a rating scale as well. So it wasn't too much effort for staff to complete. I was really honest with the time that it was going to take to do it as well. Sometimes also providing paper copies and presenting them to the wards if they didn't have time to scan their phone or anything like that. And sometimes I would just go to the wards and just wait. Just like, everyone scan this code. Now do it. Thank you.
Nice. Good strategy. Good strategy.
So that worked quite well. I think I got in the end around like just under 20 responses, which I was quite happy with. But obviously recognizing that's definitely not everyone who's giving an injection in Northwest, but it gives us a good starting point, I think.
Nice. I'm going to pivot to Felicity first, then Ben, because they might have had. I know Felicity had a different strategy, and I'm curious to hear Ben's strategy too. Surveys are tough. You cannot set and forget a survey. Kate's right. If you want people to fill it out, you have to chase. Like, you have to sit down. You have to work super hard at it. Felicity, tell us about your strategy to find out what your gaps in your bridge were.
So after we identified what the thing was, Ray, you're talking about.
What you know what your thing is.
Yeah.
So how did you figure out why they weren't? What was the problem? How did you figure out why weren't they doing it?
Why weren't patients getting enough assistance at meal times? This was a bit of a multi-pronged approach. So we were very gifted with the fact that our eWalk Engage were really, facilitators were really engaged with our project. So they obviously had on the ground experience from patient stories and just observations of the wards, and they would regularly have ward meetings. So they would get a lot of nursing feedback, etc. We did, at the 3-month mark of implementation, we did focus groups with all our various stakeholders. So we did focus groups with our with our volunteers, with our nursing staff, and with our MDT, with our speechies, dietitians, anyone else, MPAs, our multi-professional assistants working with eWalk Engage, everyone else engaged with the project. And we found multiple barriers at that point in time. So nurses were deprioritising meals to deliver other cares, so giving medications, or often a handover was scheduled at the same time that lunch was, which was something that was viewed as a non-negotiable by nursing staff. So that posed barriers for prompt care at mealtimes. And we often found, that patients just didn't want to ask for help and all that sort of stuff too. So the focus groups added an extra layer of quality to our data that we knew there. What else am I missing, Ray?
Oh, I think it was good. I knew you did the focus groups. Yep, no, different perspective. Ben, what did you do to identify your gaps?
So we're quite lucky when, we fell onto the research for the ERAS-A, and there were 17, items that need to be looked at. So we did a bit of a needs analysis and mapped that to what the current state was, and obviously then were we going to look for that future state, and then identified what strategies need to be implemented to make those changes, and who we had to speak to, what stakeholders, and that. So it's quite handy when it's well laid out for you in that sense. I guess just pivoting back to the survey comment, recently I did a national Delphi survey. So it's several rounds of a survey, and yeah, I can definitely stress the difficulty in getting people to respond. Mine went out nationally through various associations in the orthopedic and physio setting, and the numbers are low compared to how many practitioners are out there, and people are time poor. So it's looking at those strategies, and Kate touched on is championing through people on the ground and saying, hey, can you go speak to your team and say, and physically, if it's, again, paper's not great because it's harder to analyze, but QR codes, sending links, email reminders, but also setting out some expectations of your survey. What is your sample size that you're needing to get to allow translation of it? So there's a lot of literature around what sample sizes are required for variety of topics. So for me in a Delphi survey, if I got 60 and I got 75 initially, I hit the mark. And so, yeah, it's setting those sort of expectations.
Nice one. Nathaniel, do you have a question?
Yeah, thanks. So I'm from Queensland Health and Office of Research and Innovation. So I'm actually really interested to hear about all the translations that's going on. I had two questions. I was wondering, first of all, how did you get endorsements? What was kind of the process of endorsement to actually initiate these projects and get them underway? And once they were underway, how did you actually acquire the skills to actually implement, the implementation science skills to actually do the work? Because obviously that's a different skill set to core clinical work.
Cool. Okay, so Ori wants to know the goss. All right, so first of all, Ori wants to know, how did you get it through ethics? I'm understanding, is that right? How did you get approvals for this? And where was your
not even just ethics, but also local endorsement, getting the go ahead from up above to say you can use your time to do this, essentially.
All right, go Ben. Kate had to leave.
Yeah.
She's got a pre-organised meeting. Sorry, guys. Go, Ben.
Happy to speak to that. Probably, again, I can speak to both, pretty much all of my projects, is identifying that person. Say, for example, with physio and orthopedics, I need to have an orthopedic surgeon on board to run that. So I went to my champion there and ran it by them, and to see the feasibility of doing it. That then, escalated up through all the leads within the orthopedic departments. All the consultants then had to get on board for ERAS. Then it goes out wider to the other areas. Then for my time was petitioning with my director for in-kind support, which unanimously they supported. And then for that project, we actually ended up presenting outside of the CHIS. So we obviously needed to get an ethics exemption, which you would think would be simple, but it did take some time. Like any bit of paperwork, there's always little roadblocks here and there. But yeah, I think that would be my answer to that question.
Cool.
Oh, sorry, I did want to add the actual translation of research. I would do a shout out to the RTRIP initiative. So I was one of the first rounds
You're
of that
guinea pig,
iteration.
man.
I think so, yeah. After that, they rolled out some more regional groups. But yeah, I think that and the RTRIP team, Ash Cameron, who coordinates that, is an exceptional program. And we put, I think I put 1, 2, or 3 of my staff members I've encouraged to go on it, and they have gone through the process and found it very beneficial, especially when you being a clinician and translating into that research field. You don't know what you're doing. You don't know what you don't know. You get to ask those questions that are, in your mind silly, but they're actually not. And so it's just promoting that growth in that space to engage in translating the research.
And just as a heads up, we have a research translation course that kicks off in 2 weeks, dedicated solely to Northern Queensland. Felicity, you went a non-traditional approach, really, to get your stuff up and running. Tell Nathaniel about that.
Yeah, so we, I guess, just to initially get the idea over the line, myself and a couple of our very keen dietitians madly scrambled through the internet trying to find examples of where volunteers have been used safely in other hospital and health services, to provide a little brief for our management team to say, oh, okay, they're not going to go rogue and, kill the hospital. So that was a good start. But then to support the project getting as far as it has, we actually were successful in obtaining a Shark Tank research translation grant that was part of our research symposium back in 2023. Three.
Yeah.
And so we managed to get $8,000, which worked out to be about 0.1 FTE for an HP4 project officer for 6 months. So that helped me spend some dedicated time in progressing the project further, as well as obviously much help from our team. And we, as part of that, we got TARC mentorship that came with it. So Ray has been supporting us along the way. And obviously, I think being someone who's done a lot of QI in the past, the whole idea of frameworks, knowledge translation frameworks, was probably a newish concept, going from the RTRIP telementoring series probably the year before. We got the funding that had sort of brought me around to the RTRIP suite of resources and help online, which was great. And then Ray really helped us sort of nitpick as to which frameworks we wanted to use and would be appropriate for us moving forward. So that was really helpful too. So we were lucky there.
Nice work. Does anybody else have any questions for the panelists, for Ben and Felicity? So I have a question. I have several questions, but the one I'm really interested in for you to give is that takeaway. So what I'm interested in is what are your top 2 pieces of advice that you would give to people who are starting this process, who are interested in starting this process? What are the 2 things that you would tell people to do or give them advice to do? Felicity, sorry.
Yeah, funding. Really helpful to have protected time. So Ben, it sounds like you've been really fortunate to have your management team behind you and supporting you with the in-kind time that's needed to progress the projects. We also probably would be in a similar boat, but we wouldn't be as far as we are now without that dedicated, protected time. And probably the other thing is that choose something that you're super duper passionate about, because these projects take a long time and you still need to be passionate at the end, as you were at the beginning.
Oh, I like those tips. Thanks. Ben, what are your tips?
I'd agree with Felicity's. I guess I would just add clear expectations of what you want to achieve. Be persistent. It comes down to aligning with your key stakeholders and patience. Things don't happen overnight in this space, and you've got to have that passion and drive to see it through.
Excellent. Thanks. Last questions from the floor, or any lasting thoughts, Felicity and Ben, that you want to give the people? Last questions?
Utilize.
Sorry, go on, Blake.
Yeah, utilize TARC. TARC's an awesome resource. It's free. It's a wealth of knowledge. And by it, I mean Ray. So use Ray.
Yeah, that's fine. But that was also, as we were going to say, as a lasting thing, guys, you don't have to do this alone. RTRIP is brilliant. I mentor with RTRIP. We do this. This is fine. The Research Translation Centre, TARC, is embarking on its research translation course coming up. EOI is closed today. Movie butts. But look, you don't have to be alone. It is not necessarily difficult, but I love Felicity's concept about it needs to be something that's important to you. It needs to be able to sustain you. And then you need someone like Ben as a manager to sort of push all his team ahead. And I know some of Ben's peeps have already put an EOI into the course, so I know that he does this on a regular basis. So look, thanks everyone for joining us. If you haven't looked up TARC, look up our website, check it out, see what we're doing. But let us support you in your research project. Our remit is to rebuild your research capability and capacity, and research translation skills. So have a nice day. You've got 9 minutes in your day that you didn't have a minute ago. All right. See you later, guys.
Thank you.
See you, Ray.
Thanks. Perfectly done. Thanks.
You're welcome.
Interesting that you've got Ori here and NHMRC interested in this space. There we go. Well done, you.
Thank you. See y'all.
See you later.